We train for many years, so we do have one of the longer residency trainings. We spend a lot of time going to courses and pursuing things like fellowship after residency to become very comfortable with it. But it's like everything in medicine, it's an ongoing learning process. So you continue to learn, you continue to advance, you go to courses, you teach courses, you learn a lot from teaching because you really have to know what you're talking about. And anytime you're in those areas, knowing your anatomy and being able to recall previous cases, previous differences that you've seen is really, really valuable. So that I think you lean heavily on your experience and your training. I think the most important factor for a safe operation is a surgeon that's using something that he or she feels safe using. So you certainly don't want to just adopt the new shiny thing, as you said, just because it's new. A lot of the new equipment that comes out now does come along with a process of training and learning to use it and spending time with folks that have learned to use it or going to courses to develop that expertise. We also have other opportunities to practice, whether it's on models or cadavers. So we go into the OR not for the first time using something. But sometimes it's important to hang on to what you've done for many years as well, especially if your outcomes are good. We've seen things come and go. We've seen certain new, shiny instruments come and go, and they're not always necessarily an improvement. So I think keeping in mind what your goals are as a physician, as a surgeon, and then trying to understand whether this new piece of equipment really adds to your toolbox or whether it's a distraction, I think is really important, because we're constantly being presented with new and different instruments, and they're not always improvements. Absolutely. I think a lot of the abnormalities that we see around the pituitary gland, for example, tumors of the pituitary gland, tumors of the ventral skull base, which is a part of the skull base that lies underneath the brain and above the nasal sinuses, and part of the skull base that's actually in the very back of the nasal sinus cavity, kind of behind between your throat and your brainstem, if you will. These are very treacherous areas to get to. And the traditional approaches to these areas used to be very large openings to come from the side and try to come around the brain. And a lot of that now we're doing without any external incisions, because we can come through the nose and sneak in, through these cavities. I think in those instances, the minimally invasive approach certainly has benefits, and a lot of groups, including our own, have looked at our outcomes and found that it is better. But it is, again, there's a learning curve that goes along with that to be comfortable doing it that way. Well, there are many now, because I think it's become very popular in the last decade to 2 decades, actually. There used to be very few groups around the country, and when I sought out my fellowship training, I went and found one of those groups because there weren't many. We're pretty excited because we feel like in our region we're one of the few groups that's doing it. So we feel like we're offering something that is a little bit unique and innovative. But there are many folks around the world that are doing this kind of work, and throughout the country there are a lot of thought leaders now in this field. And I think for so many years many of us have seen patients with neurosurgical disorders have difficult outcomes and have difficult recoveries, and so we're all, I think, excited that if we take the time to learn and become better and adopt new techniques, that our patients are going to benefit and outcomes don't have to be what they used to be. We don't have a centralized way to do that. The internet certainly made it a lot easier for folks to look around and do some research on their own, and so it's not uncommon that some of us receive email messages. I've had patients from all over the country, kind of look you up and ask you to take a look at their scan and give them your opinion on something. So I think some patients are very proactive and they do seek it out. I think other patients will sort of follow the recommendations of their own referral pattern, starting from their primary physician. And we do have specialists, there are many specialists in the community that are neurosurgeons that will refer patients to me because they know that I have this interest. and vice versa, and I'll refer patients to them when I have something that they're particularly, focused on. So I think overall we're trying to be more targeted with where we send patients, but it's not as organized as you suggested.